Today it is December 9th in 2024. We are just a few short days away from my birthday, so I am accepting all gifts, including gift cards, cash, and nicely wrapped presents. But
Surprised you didn't put your Venmo out there, Sean.
but my very nice. But my present to all of you is the wonderful cast of characters that I have sitting before me. Christine Hall, Stephanie Aller, Paul Spencer, and Terry Fletcher. We have a great program lined up for y'all today. We're so excited to be with you. Um, a couple of things, and I don't want to spend too much time on this because I know we have a very angry Terry Fletcher today, and I'm looking forward to listening to Terry kind of go off on this. So, a couple things. I'll start off by obviously talking about the 800-pound gorilla, which is the targeted assassination of the CEO from United Healthcare. And I do want to say this very quickly. Um, Irrespective of anything that you feel as a healthcare professional, whether you're a provider, you're an administrator, you're a C-suite, you're a coder, biller, medical assistant, dealing with delays, denials, appeals, audits, all those kind of things. It is frustrating. There is no doubt. It makes us angry at times. It frustrates us. It takes us to the brink of saying, "Ugh." But at the end of the day, there is absolutely never a reason that, in my mind, rises to the level of being okay for murdering an individual. This is somebody who was a husband, a father to two children, a son, a brother, an uncle, a nephew, a grandson, whatever it may be. I have seen a lot of comments on LinkedIn about, you know, people saying, God should have mercy on him and God should forgive him for his sins and this and that. Listen, y'all, I'm not one to ever talk about, people's personal feelings, but I think it's very insensitive to put things like that out. That's my personal opinion. I don't speak on behalf of anybody who's on this program. I don't speak on behalf of Doctors Management. I'm speaking on behalf of myself as a human being. A man was robbed of his life at a very young age, regardless of what you think of this individual. And um, nothing I say is going to change that. Nothing I say is going to make it better. But what I would ask is for people to not make these heinous comments and say things that are very disturbing and beyond reproach in some cases. And I really hope that, you know, um, CEOs of other health insurance companies are taking proper steps to ensure their protection. This man knew he was receiving death threats. He made this very clear to his company. He made it clear to his wife. And still, my hope and thought is that they capture this fugitive and he is brought to justice swiftly and pays a dear price for the taking of human life. With that said, I will try to make everybody kind of laugh for 2 seconds now. Since I was serious, I was sharing with Christine and Stephanie just briefly. I got a call this morning. I have been trying to get into my dermatologist. And if any of you go to a dermatologist, it is a very extended wait to get into any dermatologist these days. But I got a call this morning at 9 o'clock, and they said if you could be here by 9:30, we could get you in. And I was so excited. So I went in and got my annual skin check, and I had them deal with something else that I didn't like. And um, as the nurse practitioner who was taking care of me got up, she said, "Hey, by the way, would you like to do something about your hair loss?" And I looked at her and I said, "What?" She goes, "I could write you a prescription for finasteride." And she said, "It's growing hair for people." And with a very straight face, I looked at her and I said, "Why would I need a pill for my hair?" And she just kind of went, and I said, Am I losing my hair? Is there something that I'm not seeing?" And she just kind of looked at me and said, "Well, it will also help if you have an enlarged prostate." And I said, "Not heard that I had one of those either at this point right now." But I kind of laughed afterwards and I said, "Yes, I would be happy to try to do something to regrow my hair. As long as it's not growing hair on my back or my ankles, I'm happy to give it a run." Of course, I had my frustration because I went to the pharmacy to pick up my finasteride prescription. And of course, my pharmacist said to me, "Why are you seeing a dermatologist for a prostate problem?" And I'm not going to say his name because he's told me he's listened to the program before, so I'm not going to make anybody embarrassed. And I said, "Well, she told me it's for hair growth." And he goes, "Yeah, good luck with that. You owe me $29." I said, "Why do I owe you $29?" He goes, "Because it required a prior authorization."
Oh, geez.
So anyways, I guess maybe over the next few months, we could track my hair progress to see if I'm growing anything. Maybe it would be like one
Like
of
a
those
chia
chia
pet.
pets.
Yeah.
Yeah,
So-
there's a couple rules out there that I think people need to pay attention to. If you're in an elevator or you're somewhere and you see somebody who may be overweight or losing their hair or something like that, it's not a good idea or a good plan to say, "So when do you do?" Yeah, you know what? That's not a good idea.
I have
And
made
then-
that mistake.
That's not a good idea. Somebody might just be a plus size person. The other thing, and Sean, this is just funny. My daughter had to called me. She's 29. She's a teacher in Arizona, married, her own life. And she's like, "I'm trying to get an appointment with an OB-GYN. I did what you said, mother. I got my primary care, got all that taken care of," because kids nowadays don't want to do that. But they did it as a virtual visit. I'm like, how do you do an exam head to toe in a virtual visit? But I get it. Christine, I've talked about our kids. I know how they are. But then she said, "Yeah, they want to do that virtually too." I go, "Okay, how do you do a pap smear virtually? I'm just curious." And she said, "That's what I said to them." And she's like, "Well, there is a way that what we do." And I'm like, "You're kidding me." I said, "No, no, no." And she goes, "I know. They said, will your husband be home at
Oh
the
my
time?"
god.
And so I'm
fried
like,
green
you know what?
tomatoes.
I know my daughter is an adult, but I'm like, you know what? Give me the phone number. So I actually called them and I'm like, "Look," and I tried not to be, "Do you know who you're talking to?" But I was just like, "You've taken the virtual visit to the extreme," since we're talking about telehealth today. I'm just like, "No, you need to get her in. She had a female issue a couple years ago. You need to get her in and do a physical exam. That is ridiculous." They're like, "Well," and I'm like, "Unless I can report you, that would be fine." "Okay, we'll get her in. Is next Tuesday good?" I'm like, "Yeah, you think?"
That
Are my
reminds me
home
of the
collection
movie.
kits
Remember the movie Fried Green Tomatoes?
Yeah.
There was a scene in that movie. That's exactly where my mind went. Like, if you haven't seen it, go see it, guys. It's been around for a
I
while.
see physical therapists trying to get caregivers at home that are not, licensed or anything, parents, spouses, whatever, partners, trying to help out with, the virtual PT visit, which I hate because they're not getting the right readings. But to say that you can do a pap with, I'm sorry, go ahead. See, Sean, your hair loss is not quite as funny as mine.
just to quickly rewind to the subject of hair loss, I actually had a haircut for the first time in 5 months this past Saturday. And at the salon where they were sweeping up the hair clippings that came off of my head, it actually jammed the machine that captures them in order to quickly clean them up. So, Sean, if it's a matter of that, we can save the clippings from my next visit. And it's a little salt and peppery, but I can guarantee you a Billy Preston type hairdo in 3 easy steps.
Well, here's what I will say. I have very little, and it is salt and pepper, so it could work.
Okay.
If you want to make me a wig. All right. Enough talking about
Wow.
wigs and hair and all that kind of finasteride and BPH. Let's jump into really what's going on in healthcare because with the release of the Medicare final rule for 2025, it has created a lot of heartache, a lot of heartburn, a lot of anger, and a lot of thoughts, questions, and comments. Tomorrow, I am actually doing a presentation for the National Alliance of Medical Auditing Specialists on the entire 2025 final rule. And I'll also be talking about some of the other things that I believe the Office of the Inspector General is going to be focusing on, along with the Department of Justice. So it should be an interesting conversation. I'm looking forward to that tomorrow. If anybody's interested, it's NamUs. You can look it up. But I want to jump straight into telehealth because, folks, telehealth is not going away. They're expanding the service offerings for that into 2025 and beyond. But there are a lot of things that you need to understand that are creating a lot of heartburn for our team. So, Terry, I'm going to start with you because you are the telehealth Yoda, and then we're going to kind of kick this thing around and talk through this and try to help our viewers, listeners really understand how to do these services the right way, because they're not being done correctly, and they're probably not going to be done correctly in the future.
Yeah, thank you. And I kind of try to be a co-Yoda with Christine, but it's funny because, and not in a ha-ha way, one of the things that I've been touting ever since the 2020 COVID is that, well, first, everyone's heard, you can't put, what is it, the chicken before the egg, or the cart before the horse, all that. But the problem that we're having is that, and I know that the former, well, she's still VP, but the former presidential candidate who was in charge of internet, $42 billion allocated, and nobody's been connected yet. So now we've got Elon Musk stepping in with Starlink and everything. But that's probably the crust for me, is that we don't have internet connection for so many millions of Americans. And let's just say thousands and hundreds of thousands of people that are in the rural areas. I feel so bad for the people from the flood zones. I mean, I know Stephanie's husband has been out there rebuilding and helping, and they don't even live in that area. And looking at, just access to healthcare. So everybody's, when I talk about the cart before the horse, they're jumping right into, I want this covered for money, instead of, well, first of all, isn't the big buzzword out there equity and access? Well, if you don't have access for everyone, then how is it equal access? And and the one thing is, to be able to give somebody a service, you have to offer it to everyone. That's like the rule. I mean, Medicare, Medicaid, I mean, that's the rule in California for sure. And so I don't understand how that has been overlooked, more so than what we're dealing with the legal hurdles we're going over with telehealth right now. And what that means, just so everyone kind of knows, if you haven't read your final rule, it's only 3,033 pages, but there's certain pages in there that, you can go over there. It starts really at page around 130. But if you look at page really, I think 230 to 248 around there, Christine, right? That's about where we're at for telehealth. You can see what they're talking about, that, and they even mention it in the final rule. When they talk about audio only services, for example, they've done away with the telephone call codes and CPT in 2024 or 2025. There is going to be still the virtual check-in, the 98016, that's going to take the place of the G2012. But that's basically just saying you're calling to see if you need to come in. And if you don't, you get $10. And if you do, you don't get that. You add that time to your visit when you come in. But as far as having a telehealth encounter that is audio only, unless it's behavioral health or end-stage renal disease, or what was the other one, substance abuse disorder, then you're going to be out of luck. And there was something in there that's very gray. It's very ambiguous. And it says something like, well, if the patient refuses or doesn't have it, or doesn't have, and they gave examples, doesn't have internet connection, but the doctor has to have the audio and video options, then we may allow it with, but they put in there with the appropriate modifiers, 93 or I think it's FQ, because those are that is for the mental health. But here's the problem. People aren't seeing that. They're thinking, oh, now I can bill a regular E&M service audio only in 2025. All I have to say is, you don't, to the patient, you don't want to go audio and video, do you? And that's not okay. So I'm going to kick it to Christine Terry, at this point. Yeah, because this is it's just going to be a nightmare at this point.
There's a lot of moving parts right now.
There is.
The first thing is, Terry, in the 2024 CPT book, the AMA gave us some awesome guidelines for when telehealth is appropriate. Now, AMA doesn't guarantee that anybody's going to pay for any of the codes that are in the CPT book. We know that. These are just codes that are used to represent services. And if there is a benefit from the payer and the requirements are met, then the payers use those CPT codes to reimburse us. So first thing is, if you haven't become reacquainted with your CPT book, go and take a look in the instructions of the guidance that's been given of when telehealth is appropriate. So from that level, the next thing is we're talking about the final rule for CMS. Now, I want everybody to remember CMS is for Medicare, but CMS also influences a lot of the payer policies out there. So when CMS is talking, other payers are listening. The other payers, they need to follow the state guidelines. And if you don't know your state guidelines for telehealth, that could be a problem too. If you're in the great state of Texas, you've got to have consent documented for every telehealth visit, or it's not a viable visit, regardless if it's paid for or if it's not paid for.
We talk about California if it's Medicaid.
Yeah. And we talk about Medicare now with the statutory versus administrative. So certain rules of Medicare are administrative, meaning Medicare can come in and they can say, yes, we're keeping it. No, we're not keeping it. We're going to do this. We're going to change this. And that's okay. But some rules are considered statutory, and they're going to require Congress to come in and make a permanent change. That's where we're at right now with this final rule. The final rule is administrative, what Medicare can and can't say. The place of service that telehealth can be reimbursed for Medicare, and the patient's geographic location reimbursement for Medicare, that can only be changed by Congress. That's going to require congressional intervention to change. It's totally out of Medicare's hands. And at this moment in time, we've got a lot of bills on the floor for Medicare. There's over 20 of them, right, Terry?
Yeah, and you said something about Medicare that's got to be changed by Congress. What I think a lot of people are missing, just so you know, we're under a temporary waiver still. We're still under a temporary extension from the pandemic of last couple of years, meaning that through the end of this month, if the patient is in their home, any patient, doesn't matter who they are, through Medicare, they are covered under telehealth if that's the platform that's appropriate. But as of January 1st, that part of the waiver, again, like Christine said, without congressional change or oversight, or if they don't update the Consolidation Appropriations Act, which is what covers all of this, then they go to pre-pandemic geographic location. When what that means, because some of you haven't even been working in healthcare, before the pandemic, is that it's still covered if they're in their home, but as far as the place of service, but the geographic location of the patient has to be in a healthcare depressed area, meaning there's metropolitan depressed area, meaning Area 99. The patient doesn't have an option of a physician within, I think it's a 55 mile radius. And there's a list of it. It's HRSA.gov.
There's an analyzer.
There's an analyzer that does this. So if you're in a metropolitan city and I had a doctor say, well, all my patients are rural, that's not enough. Just because if you're 15 minutes to that patient from that patient's house, they're technically not rural. It's rural. So you have to look on the list. And I would say 85% of patients are going to lose their telehealth benefits under Medicare and some Medicaid. State Medicaid is making some exceptions there. And if it's not behavioral health, and if it's not substance abuse disorder. So be really careful with that, because I'm seeing a lot of patients or a lot of practices, and Stephanie, I'm going to kick it to you on this one, and Sean and I've talked about this at length. I think Paul and I even discussed it, that decided once the pandemic hit a year, these are going to be, just grandfathered in forever. And they made a practice model based on the COVID-19, pandemic. And that we try to discourage it. I know how many times do we say that on here? It's temporary. Even if it was temporary for 3 years, it's temporary. Stephanie, I know you've got clients that are doing that.
Yeah, that right there is just the problem, because there's so many companies out there that have opened up and created their entire model. I even have a client that is newer to me this year. They opened this year and opened on all of the waivers, and they're questioning to some extent, and it's like, okay, even if the core of the service that you're going to be rendering is still allowed to be done remotely, you still have requirements in there like remote, or not remote, but an initiating visit with the patient. When we think about all of these management services and all of the companies that exist with chronic care, principal care, remote patient monitoring, all of those different things, you still have to have that relationship with the patient. And some of my clients are set up in a place where they don't even have a physical office that a patient could come into. They may have a corporate office, but they don't have a patient clinic that they could go into. So that's going to be problematic on a lot of levels. And the other thing I wanted to highlight, Christine, what you said about the state side. I actually had a client reaching out to me. One of the things that I'm finding with my clients that have either all telehealth services or a majority of their practices telehealth services, they have expanded into other states, and I'm not always made aware of that. So I had a situation come up where they were asking me, because a physician assistant was worried that she was working outside of an allowed scope in a particular state. And I'm asking them questions, and I didn't even know that they were in that state at the time. But one of the things that the state did highlight was they were talking about who's allowed to perform telehealth. And in that particular state, physician assistants are limited depending on the type of service. So that website, Christine, I don't know if you put that in there or not, the CCHP. I can put that in the chat.
Oh, no, I didn't put the CCHP in. I put the analyzer, and I also put in the Medicare claims processing manual, chapter 12, section 190, because that gives us our original 2016 telehealth benefits that we're going to be reverting back to. So, a lot of things that we do here on this podcast, we give you the tools for you to go and take a look at it, so that it's not just a Terry said or a Sean said or Christine, Stephanie, Paul said, that here's the actual guidance that we're going to have to start following, and where you can find it, where you can empower your practice.
Well, I have a
Yeah,
question
so
for
with
Paul.
that, oh, sorry, really
Go
quick,
ahead,
with
go
the
ahead.
CCHP link that's in there, they have federal, but they also break it down by state. So go in there, look up the state that you're working with, or, if you find out that your client's practicing all over the place, look up multiple states and see what that says.
There's 44 states that officially have telehealth specific guidance. So, 44 out of 50 means that you've got to do your homework.
But it's
You
not blanket
probably are in a
guidance, just so
state.
you know. Yeah, a lot of people
Correct.
say, oh, if they're on that CCP website, they think they've got everything that was in the pandemic. No, no, no. It means that you've got specific out of state rules that you have to follow, and your state might allow it, might not, and it's going to be different than other states. So, Paul, I'm running into something with clients. I think maybe our listeners might be. I thought I'd throw it to you. With the new codes that are coming out, you saw that the CPT put audio only and put audio and video. And so I was very disappointed that CMS isn't recognizing them. That would make life so much easier, but I know that's not their goal, to make our life easier. But my concern is how they worded it in the final rule. I don't know if you noticed it. They said that they're putting those codes in invalid because other codes are more appropriate. But when you look at the E&M codes that are still on the list, and Christine, I pulled up a list, I think it was from November, that's the most current, they aren't the most appropriate because they don't say telehealth, and instructions for use are to use the code that's most appropriate. So it's going to confuse a lot of people. How are you going to instruct clients as far as, do they have to have mirrored codes?
Well, I have some insight into that because I attended the AMA
That's what I'm
CPT
asking.
symposium.
Yay.
They are indicated as telemedicine services. The one curveball that I can throw to you about that code set, though, is that even though Medicare puts them in an I status, they assigned an RVU value to all those codes. So if you're going to use them
I
for,
saw
say,
that.
a commercial carrier who is not indicating whether they're going to accept the codes as of 2025 or not, big curveball there. At the very least, you can get close to a fee for these services because there's an RVU value set. I can't predict whether that means these codes are someday going to be accepted because they have an RVU value in the bullpen somewhere and somebody needs to research exactly what these codes mean. But it was very clear from the AMA definitions, and I thank Dr. Holman at the AMA, who's always entertaining and always brings these issues to light in a very clear and concise manner. They, at the very least, have a crosswalk in their head as to where these telemedicine visits fit on a one-to-one basis with E&M services on the audio-visual portion of it. On the audio-only services, it's not quite as clear. It's a little bit murkier, even though it has to do with medical decision-making. But I honestly believe that Medicare is kind of outlined exactly where their head is at as far as telemedicine services in 2025, however misguided that may be. Honestly, it's December 9th, and the great undiscovered country is what commercial insurance carriers are going to do with this, and whether they're even going to accept these new codes or what their telemedicine policies are, because I'm not seeing it in medical policy bulletins that have hit my inbox thus far.
Well, I think one of the people on the panel here is going to have a really tough time is Sean coming up because Sean, you're going to have people, I would say in about 6 months going, hey, we're getting in trouble because we're feeling this wrong and we need help because we're getting, targeted. And I'm just going to
they're
be,
not getting paid.
yeah, or we're not
Yeah.
getting paid. Well, because Sean, here's the big thing that I'm getting feedback from. And I know we all have clients. So you guys tell me if you're getting the same thing. People are interpreting it differently. And Christine and I, we had to go through and we sat, virtually, but together going through the final rule, highlighting it, saying, oh, wait, but look what it says here. Oh, wait, but read down a little further. And here's
Well, clarify the
thing.
audio part of it, Terry.
Well, yeah, because the audio only, it was basically saying that if a patient was unable or refused to be on camera, and they gave reasons why, one was internet or one was they didn't feel safe, somebody seeing in their house, that audio only was appropriate. But then you had to read down when everybody stops. It's like, okay, you can't just clickbait. And then it talked about the behavioral health and the SUD, so the substance abuse disorder. And people stopped reading that. So I'm still getting questions saying, does that mean that we can now bill office visits with audio only? And we're like, no, it means for certain situations, if the patient decides that that's not for them as far as audio and video, and the diagnosis is such, then that may be appropriate. But it looks like it's and I'm seeing a lot of people reading into the interpretation of these rules to fit their own agenda. And we've been telling everybody for 4 years, you cannot bill audio only for office visits. And now they're reading the rule as that you can, but it's only if. And I'm very concerned at what can be out there because actually, Sean and the rest of the panel, there's been some respected consultants that I respect that have put on LinkedIn and have put on social media those things that you can do that without safeguards, and they didn't put in the details. And I sent it to Christine. I think I sent one to Stephanie. I'm like, oh my gosh, look what this person just put out there, and they didn't clarify, and people trust them. So Sean, I'm going to let you jump in here, and that's going to be a problem.
Yeah. So a couple of quick things that I would say. The first is, if a patient indicates under these conditions for behavioral health or substance abuse counseling that they do not want to be on video for whatever the reason, make certain that you have that statement from the patient, repeat it, make sure the provider who's doing this says, Mr. and Mrs. Patient, I just need to, for the record, make certain that you are attesting to the fact that you do not wish to be videoed for this telehealth visit. for your behavioral health counseling or for your substance abuse counseling. That goes into the record. The other thing that I would also do, I would try to be preemptive with this stuff. And I would let patients know prior to the telehealth, um, if they do not wish to be on video, I would have an attestation form that you send to the patient electronically, and they check a box and they do that PDF automatic signature, or, DocuSign, or whatever you want to refer to it as. And they just click the box, they type their name in, and it does a little signature, and it's an attestation that says, I, Sean M. Weiss, am participating in a telehealth session for substance abuse counseling or behavioral health services. I do not wish to be on video. I only am agreeing to the audio portion. And that goes into the record because, again, to Terry's point and to Christine's point, this is going to be big business for the special investigative units of the commercial insurance companies. This is going to be very big business for the targeted probe and educate for the Centers for Medicare and Medicaid Services. And I would not be surprised in any way, shape, or form with the Office of Inspector General getting into this, because their desk audits, keep this in mind. If you go through a desk audit with the Office of the Inspector General and they determine that you have an obligation to make a refund to the program, or they hit you with what's called a civil monetary penalty, they start at double damages. It's not the assessed overpayment. It's the assessed overpayment, the actual dollars, multiplied by 2. And if you argue with any of the attorneys from OSIG, which is the Office of Counsel for the Inspector General, they will tell you, you're very lucky. We actually have the right to assess treble damages, which is 3 times the amount unlawfully claimed. So be very careful with this stuff. I think the last thing that I would say on this as well, you got to have a policy.
Yeah.
You've got to have a policy in place. I preach this day in and day out. Compliance is not a destination. It's a journey. It has got to be a living, breathing document. It cannot be a static PDF or Word document that lives in a 3-ring binder on a shelf collecting dust, or something that lives on your computer that hasn't been looked at in years.
Sean, I have a question though.
Yeah, go ahead, please.
We have people that, and everyone hear me when I say this, and I'm saying this to our listeners, that and I feel so bad for administrators and office managers and, everyone out there trying to facilitate this, because they come to us. I know my clients come to me and they say, the doctor wants to know where it says that in writing. Perfect example. When the rules for the Office of Civil Rights and changed and said, or I should say, went back to pre-pandemic and said, you have to have HIPAA protected platforms. You can't use FaceTime, Skype. You definitely can't use TikTok. People are doing all kinds of weird stuff. You have to use HIPAA protected platforms, like, your EMR or whatever. And it was in writing, and they gave them 90 days after the pandemic ended. So as of August 9th, 2023, you had to have it there. So I instructed my clients, put it in your record. Like Sean said, have a policy, put in your record so you're protected. And I got so much pushback because the published guidance from Medicare didn't say you had to have it in the record, but the published guidance from OCR said now you have to have that as far as the type of platform. So the argument was being made to me from the providers saying that we don't have to put that in there. They assume that we're doing the right thing. And after I'm face planning, I'm just like, why would you leave it up to that assumption? Why wouldn't you just put it in there?
Terry assisting you or Sean having to assist you.
There you go.
Right? Just because it doesn't say you have to, doesn't mean that you're not going to get in trouble. It doesn't mean that you're not going to need to call in Sean and the doctor's management team to come in and now do damage control. So you can either take the proactive advice from Terry or call Sean. Either way, right? And I wanted to say, there are 6 telehealth audits that the OIG has already completed. There's 4 reports out there. 2 are continuing to be ongoing. There is a toolkit that the OIG has given us. And essentially it's saying the same thing that we're saying. Listen, you have to be you are responsible for knowing what the rules are. And if you don't follow the rules, then you're not entitled to the money and someone's going to come back for it.
Well, and
That's
let me
the
just add one
short
thing.
version.
Our incoming HHS secretary, Robert F.K. Jr., love him or hate him, and I'm the jury's out yet. I love the Make America Healthy thing that platform he's on, but he is a very litigious person, and if he thinks you're doing something wrong, he's going to refer you over to that, OIG statute. And I'm telling you, it's going to be really tightened at this point. It's not going to be a free for all. And because they all know in coming administration all the waste of expenses and expenditures, and we have to get back to getting the little bit of flush fund here for Medicare and some of the programs we need. And I truly believe that there's going to be even more. I think, Sean, if you're thinking about retiring or going to your winery and having a nice, comfortable chair, think again, buddy. But I just think it's going to be, you too, Paul, but I think it's going to be, even wider. I don't want to say speculation, but scrutiny. How about that?
Yeah.
As far as telehealth, because we've seen so many bad actors. And unfortunately, and this isn't a bad actor thing, this is just, to me, poor judgment as far as having a practice set up based on temporary waivers. I can't tell you how much I'm disappointed to hear that people did that. I mean, Paul and
Yep.
Stephanie.
Yep. Can I add a personal anecdote on that subject?
Yeah.
So I've been seeing a hematologist, and I've only seen the hematologist via virtual medicine. And I think I put this in an email exchange with the group, but I wanted to read it out loud to the listening audience because it's very revealing about where the preparation in the medical community is right now, which is at just above zero, or perhaps at zero, or just below zero. I wrote to my hematologist saying, as a medical and compliance professional, I think you need to know that the rules are changing on January 1st, and it might be a good idea to see me rather than in a virtual setting, a live setting. And the response that I got, and I'm reading it from my portal, and I'll delete the name of the practitioner. Dr. X only sees patients virtually and does not see any patients in clinic at this time. We were not made aware of any changes regarding this, and so at this time, if you wish to see Dr. X, it would remain a virtual visit. If you wish to see a provider in clinic, we can connect you with other provider scheduler. So the moral to the story is, I'm seeing another provider on January 17th in the same medical specialty. So, and understand that if you know where I live in Milwaukee, Wisconsin, you can project which enormous healthcare entity located in Milwaukee and also with locations in Illinois that I'm talking about that put this forward. I would have, having been an employee of a company that they swallowed about 15 years ago, I would say that it is time for their compliance professionals to get on the stick and start reading the final rule and putting this out to their provider clinics.
Well, Paul, I'm just glad it wasn't a prostate or rectal exam. That would have been a problem to get that kind of email.
Well,
I mean, when I heard the female exam for my daughter, my head exploded.
Yeah.
I was like, what are we doing?
Just the idea that any images of that nature could be saved eliminates that type of exam ever wanting to be happening in my house. So
I want to go back to something Terry said, right?
Oh, no.
So, they were talking about RFK Jr. Again, and I'm just going to throw it out there. I think RFK Jr. was a horrible pick for Secretary of Health and Human Services.
See, and I'm going to say I think he was a great pick. So we've got the back and forth. So that's okay.
I love RFK for the reasons that you cited. I think he would have been much more beneficial to the country as the head of the Food and Drug Administration.
That's under him. That is under the HHS.
I understand, but they're getting him involved in the Centers for Medicare and Medicaid Services, and I don't know that that's the right fit for him. But the one that concerns me even more is Mohammed Oz as the head of.
Oh yeah, I'm over it. Yeah,
I have significant concerns over Dr. Oz as the head of CMS. I've written blogs about this. If you're interested, go check them out. Look, it's going to be interesting to see what transpires. maybe CDC would have been better for Bobby Kennedy. I don't know. I get these, the big umbrella is HHS, but a little concerning. I think it was too high of a position for me. I would have loved to have seen him as an administrator over one of these, but we'll see what happens. Listen,
I think it's more because I think, and just from what I've been reading, because I'm really on top of it.
Yeah.
I think it's more because of he will be the administrator of HHS does oversee FDA, CDC,
yeah,
Medicare.
No,
So
no,
he's going to be on top of that. But I think it's also he's really going to focus on childhood disease and chronic conditions. So I think for that, that's a positive.
My big concern is with how litigious he is.
Well, that's why I said that.
Right,
Like, yikes.
with how litigious he is, it concerns me about the rollback of regulatory burdens that are placed on hospitals and providers, and his willingness to engage in more high-level investigations and going after providers. We'll see what happens.
Yeah.
My hope is that Trump can reel in somebody who starts to get a little bit away from what his platform that he ran on, which is rolling back regulatory burden and stuff like that. We'll see. Listen, at the end of the day, I would love nothing more than to see Bobby Kennedy Jr. be successful in this role, but only time will tell, right? And Trump has a history of getting aggravated and saying you're fired. So we'll see what happens. Hopefully that's not the case, and hopefully they can turn the Centers for Medicare and Medicaid Services around. I know we've had conversations and we'll continue to have conversations about the push to getting everybody into Medicare Part C, to the privatization of Medicare. I think that would be an absolute disaster for this country.
Yeah. Well, he does too. I think the thing people should also look at is policies for people.
Yes.
I was talking about that with Christine, and I know I've mentioned it to Stephanie. I talked about that with you, Sean.
Yep.
That's one thing that he created, policies for people. I think it's .org. It might be .gov. I'm not sure, but you can go on there and put in what you would like to see as a policy. Just write it up. Even if you don't have policy language experience, write it up, add it to the blog. And they're saying they're at least reading everything that people's putting in there for information. So
I'll tell you the other one that you should engage with, because I've actually gotten a legitimate response from this group, DOGE, the Department of Governmental Efficiency. It is absolutely fascinating to see the things that they are working on, the transparency that they are putting out, and the fact that they are actually taking this stuff serious. And I love the fact that Elon Musk has such a good head for healthcare, with how involved he's been in different aspects, especially throughout the public health emergency. But we'll see what happens. Listen, does anybody want to take on the conversion factor real quick? Because I think that's a quick discussion that maybe we should have. Anybody want to talk about that? Christine?
Terry, you should talk about the conversion factor, but not just the conversion factor, but all of the sequestrations and the pay-goes that are coming in place.
Yeah.
I'm only going to say that the conversion factor reduction is going to cost us about the same as an FTE for most practices. And then when you add sequestration and pay-go, and maybe the loss of telehealth and the restructuring of practices, like the first quarter is going to be kind of kicky.
Yeah. We have a proposed reduction. Well, I shouldn't say proposed. We have a reduction that's coming as of January 1st, and everyone knows it's going to be 2.93% and what the conversion factor is that is the multiplier we use to figure out times the RVU, the value of the code, what the allowable is on the code, not what you get paid, what the allowable is. So that means what will be considered, and then Medicare pays their portion, and then the patient pays their portion. So the reduction will take the conversion factor for 2025 down to $32.31. It's likened, and I do the math. I'm actually an economy major, and it was just like we had in 1972 when you think of inflation. It's awesome, isn't it? So I'm a little salty about that. And then on top of that, make sure you're looking at your explanation of Medicare benefits when you get paid. And some of you get paid electronically, so don't forget to look at that, because your checks are going to offset a little bit. You're going to have that reduction. Plus, we're still getting the sequestration 2%. Remember, that was from the Obama years, the 2011 debt ceiling increase, and then it was called the Balanced Budget Act of 2013. and that hit Medicare. They always hit the agencies that we get ongoing funding. Then the $1.9 trillion of the what's called the American Relief Act spending bill from the Biden administration from 2021. Now, who's going to pay for it? They always say, oh, no, you're not getting taxed. Well, Medicare is getting hit. 4% reduction, again, to your end bill, your check. And that's going to start January 1st, 2025. They moved it. It was actually supposed to start in 22, but because of COVID, they moved it a couple of years, and now it has not been stalled, stopped, fixed, or anything. I know MGMA has been on top of it, but they can't get Congress to do anything, like Christine said. Everyone is waiting to confirm new congressional members. They were out there trying to get reelected, and they've kind of dropped the ball on their job. They're doing things that really, to me, I'm not saying aren't important, but aren't of an emergent nature, things we need in healthcare right now. So that's a 6% reduction on top of the not 2.393% reduction. And I don't know, Christine, how does that affect Medicare Advantage? That to me is going to be a problem as well.
Well, I wanted to punt backwards a little bit to what we were talking about, Congress having to come in and make some of these changes or opine upon some of these issues. It's not that we're not having a strong enough voice. It's not that MGMA, that, the other organizations, the specialty organizations, AMA, it's not that they're not loud enough. They are loud enough. But right now, we've got, like you said, so many other obligations for the first session of Congress that many of these things are going to have to wait to the second session or the next session, like telehealth. It may come back. I have great hope and great feeling that it will come back. But what happens during that interim time? Can we get the pay-go moved? Can we get that sequestration reduced? Could it happen? Yeah, it could happen, but it's probably not going to happen for a while. So my strong advice is think about what first quarter is going to look like. You've got deductibles that happen usually in first quarter. You've got the sequestration, the pay-go. You've got telehealth that's going to come off the table for a while, even if it does come back. How is all that going to, and then the conversion factor, what does first quarter look like? How is that going to impact? Can your organization recover Q2, 3, or 4 over what happens Q1? So that's something that I think from a practice administration perspective that we've really got to pay attention to.
Yeah, and Christine, one of the things that worries me about that is when you also see things like the new advanced family practice services coming in. So they're supposed to be looking at what we do with chronic care management, for example, and kind of roll it all in and say, oh, well, you don't need time requirements. These are easier to meet. Well, we all know from our audits that that just means that people are going to see that it's a new service, see that there's a dollar amount attached, start billing it for everybody that has a chronic condition, and not pay attention to the fact that there is actual work behind that. So yes, the cuts are concerning, but even more so, I know that in my personal work, I end up having to deal with the cleanup on the back end because people are just looking for ways to get these other services in. And, it also makes me think as well, when we have additional services added that are really geared towards the primary practice specialty, what about all of those companies out there that are trying to do it and cut out that PCP? They want to be the one doing CCM. They want to be the one doing transitional care management. And I have those clients as well. And I'm always asking them, are you talking with the primary care? What is your involvement with them? Are you truly treating this patient? And a lot of times the answer is no, but they're in billing it because they know the PCPs aren't. So I foresee a lot of compliance issues as well coming out of this, whether it's from people billing incorrectly to hide what's really happening, or, just implementing new services thinking that it's easy and not really researching that.
Well, I wanted to jump right back to answer Terry's question about what also we can kind of see moving into 2025 from a Medicare Advantage perspective. Realize that the version 28 is now going to be the primary version for payment projections for data gathered in 25, payout in 26. So we lost a lot of those conditions that had value. The value for those Medicare Advantage plans was reorganized or revalued. So that's another thing to consider, is that you will see a decrease in that overall HCC score or MRA score from a Medicare Advantage perspective, just going into version 28. So again, from an administrative perspective, I can only imagine that the next few weeks for compliance and the CFOs and the admins, there's a lot that we're going to need to make sure that we put in place. And looking at those projections for the next year are going to be very different under these circumstances.
And also, Christine, this particular year, I've seen a lot of change in habits from those managed care plans on the denial side of things, especially for clients that I have that have largely a geriatric population. Entire claims are being denied on diagnosis alone. And I go in and look at what their denials for, and it's because there's, an incorrect relationship between codes, or the details that we typically have to read in small print in our ICD-10 manual are just automated on that payer side.
The
So
exclusions.
yes, yeah.
And I
So
wonder,
you just can't hide from it, and
yeah.
a lot of providers don't want to have to deal with this side, but it's becoming reality. It's not really optional.
You brought something
Shouldn't
up,
be
Stephanie, with
optional.
you brought something up with the advanced, what is it called, advanced primary care situation, and to me that's similar to the chronic care management codes, right? Except without the
Yeah.
time factor.
Yeah, they're
Okay.
saying it's easier.
Yeah. Well, the thing that I think is interesting is I'm starting to see denials, and clients are starting to say, "Hey, we're getting denials on our transitional care management," and the denials are interesting. They're because they didn't have a relationship with the patient prior to them billing. And I said, well, I tried to explain to you that just going to the hospital and getting a list of discharge patients and then saying, I'm going to go ahead and do all the transitional care management, that's not enough, because it says you have to take care of the entire patient needs once they come out of the hospital and then they're into their domicile or into their community. And a lot of these new providers, a lot of them are new, they're saying they're trying to build a practice. And so what they're doing is they're getting this list, it makes me crazy, of patients who are getting discharged. And then they're saying they're taking on that transition, but they're getting denials because then, in healthcare, mostly commercial, but a couple have been max. And they're basically saying, okay, where is your discharge and where was your hospital stay before we look at your transition? And they said, well, we don't have one. They said, well, then you aren't the provider of record for this patient that knows about their entire healthcare profile to be able to do that. Here's the problem, and I want to send it to Paul because I know you probably have comments on this. Again, I always get this. Well, where does it say in the rules and the published guidance that you have to have that? We were told. I'm like, by whom? To go ahead and do it that way, and because it's not word for word explicit, it seems like common sense is losing the battle here on
Yep.
looking at the definition or the true intent of the code. And I don't know, Paul, I'll let you take it from
Well,
there.
there are two things I can comment on. When you were describing that situation, the corollary that immediately popped into my head was anytime somebody gets into a car accident, suddenly you look into your mailbox and you get a letter from a small-time personal injury attorney who's trying to build up their practice, who says, "Hey, are you heard of?" Same thing. It's like you don't build a practice by sending out letters or going to mine information at your local hospital or police department to see what kind of accidents were happening that day. The second thing is, and I know Sean and I have pushed this before, and we continue to see it with other practices, just because a code is created doesn't mean that everybody who sees that code and reads it in either a CPT manual or a HCPCS manual gets to bill that code. It is representative of something. It could be a service, it could be a supply, it could be a pharmaceutical, it could be a wound healing matrix, right, Sean? But you have to do at the minimum the research on that code as far as coverage yourself. Do not count on a vendor who's trying to build your practice with a service to be able to give you the full picture, other than, look, I have these EOBs that show that we've gotten payment in the past. It must be something that you can bring into your practice. It's not the way that works. There are, for every code that's out there, there are levels of rules, not only on the government side, but on the commercial side, that make reporting that code very difficult. It's the same thing when we talk about coding certifications. There's theory and then there's practice. And you learn practice about 3 hours into your first coding job as to what actually goes into coding a claim properly, putting it on paper, and sending it to a payer for reimbursement that is defensible and represents best represents the services that you provided.
It's funny, Paul, because I'm starting to see denials that, and even on appeal denials, where the language from the payer is saying you misrepresented the intent of the code. I was like, wow. Sean would have a field day with that one. But it's interesting because that's not what the purpose of the code was. And then the defense in the physician is like, well, that's not what it said. It said I could do it. But to your point, it's up to you to realize, and a lot of this is common sense. Think about this, and I'll end my stuff on this, is think about the intent of the E&M codes that says it's up to the physician on what the history and exam looks like, but it has to be problem pertinent, right? Well, I can't tell you how many doctors, I think they're just trying to bait me to argue with them, but they're like, no, Terry, an ankle exam is fine for a patient who comes in with chest pain. I'm like, you know what? And they laugh because they know, it'll make me yell at them. But I think that sometimes common sense has to take over here and realize that the payers are expecting you to have it. If you're in the healthcare, profession, they expect you to look at something and say it's not for everyone. I mean, what I love the American College of Physicians, because they put out these toolkits. There's a great one on chronic care management. And in the toolkit, they said you're going to have a population of patients that don't qualify. You've done all the work, but you didn't hit your 20 minutes. You've done all the work, but this patient didn't have the original consent visit. You might have a patient who qualifies with 2 chronic conditions, but they are not going to decompensate, and they're not going to have a problem in the next 2 years that they might die. And so they are not a patient that should be having an out of pocket for this, is the big thing. And there's so many third-party bad actors and companies out there that just take, and again, I hate to keep referencing the Bible, but I get all these things. People are like, that's exactly right. People take a word from scripture, which is published guidance out there, and just use it for their agenda and don't read the entire text. And, it drives me crazy. All right, I'm over my rant. Sorry. Go ahead, Sean.
Listen, I'm totally.
He's like, why do I invite her?
Listen, we have a lot coming down the pike in 2025. I think the best thing we can do is find a little bit of patience. Let's see what happens with this new administration. Let's see if they look at some of the guidance that has been put out there that is ambiguous in a lot of areas, or that's contradictory. I mean, I think it was Stephanie and myself, or Paul and myself, were on the line with a client the other day, and the LCD actually contradicted itself with saying that you could do one thing here, but the very next sentence, it absolutely canceled it out. So it's going to be very interesting to see what happens with this new administration. I don't expect it to be on day one, but I do expect somewhere by the end of Q1, maybe middle of Q2, we should start having a pretty good understanding for how things are going to go. I think the most important thing is we need to continue to advocate. We need to continue to engage in these public hearings that they do, these sessions. Terry's always on there. Christine's on there. I know Stephanie's getting engaged. I've been on many of these. Don't get frustrated when you submit your questions and they don't take your questions. It's very rare that it happens, They started taking Terry's questions earlier this year. I think they took a couple of them, and after they got a couple, they stopped taking them after that. So I think Terry kind of wore out her welcome on a few of those. But I do think it's going to be very interesting in 2025. I am really excited about some of the things coming down the pike that I'm going to be able to share once it happens for my engagement with a couple of different members of Congress and a new member of the Senate in the heartland of America who is taking on a very keen interest in healthcare. And also the folks that I'm working with right now on the transition team for this new administration. So I'm really excited to see what happens come the first quarter of 2025 and beyond that. We have one more hashtag Terry Tuesday coming up tomorrow. This will be the last Monday coding compliance auditing roundtable for 2024 because as of Friday this week, I am going on vacation and I will not be back until sometime in January, the first week or something like that. But get onto Spotify, get onto your favorite platform, find us on there. You can find all of the episodes for 2024. We're going to have a tremendous amount of great content for 2025. And I do want to let y'all know this. Terry's going to get mad at me, but I'm okay with it. Terry had said to me, Sean, I think I'm done with the roundtable. I think I'm done. I don't want to do it anymore. You know, some of these topics are just way off for me. And I didn't really respond to her. I kind of let it sit for a little while. And I said, okay, whatever you want to do. And then last week, in typical Sean fashion, I had a conversation with my very good friend Terry. And I said, you know, you're not going anywhere. We're going to work on the coding content. We're going to work on the compliance content. And we're going to continue to have a great show. So, Terry, whether she likes it or not, will be back on the roundtable in 2025, as will Scott Kraft, Christine Hall, Paul Spencer, Stephanie Howard, because I love these guys and gals, and they put together great content each and every single week. And without any one of these folks, it just wouldn't be the same. So listen, Terry and I will be back tomorrow with an all brand new hashtag Terry Tuesday. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.